So good morning, evening, afternoon, everybody. My name is Fionei Tarbet. Today's presentation is part one. We're intending to give two different sessions, one today and one in 2 weeks' time, covering all aspects of the core histology. So this is a high-level view, and I'm going to be covering the key factors influencing the quality of tissue preparation and processing. Just as a disclaimer too, this is presentation is for educational purposes. So this is, I'm from Leica Biosystems. This is a general information centre. We are not going to be focusing on product or specific products. So just to set the scene, and whether you are in research or working in a clinical laboratory, I think we're all under the same kind of pressures these days to actually try and achieve really consistent results, but working in a high pressure environment. So for clinical laboratories, there's often a high throughput with a shorter turnaround time, which leads to more problem blocks. But in every situation, there's often less time to really think problems through. The problems are not necessarily brought to your attention in a timely manner. So often, again, my experience being very much in a clinical world, where you only find out about a problem when it's already at the pathologist and it's way past the time when you've actually aware of a problem and can deal with it. So there's more pressure for quick fixes, and staff can often be inexperienced or not fully trained. Also, pathologists may not be aware of actually what the problems are, and therefore their words would be something like their tissue isn't processed, when actually it could be something completely different and it's not in their area of expertise. You're expected to do more with less resources. There is definitely an accelerating pace of technological change within laboratories. To try and monitor, maintain and improve quality under these circumstances is a major challenge. And there's a need to think globally, which is management level, as well as locally at the bench level, to identify key factors affecting quality. So our objective is always to provide a quality service to our clients, leading to best possible patient care. However, in simple terms, that's what we aim to always do, but it isn't always that simple. We do need to produce high quality sections and stains in a minimum time, from blocks that cut easily and are stable, with accurate identification and labelling, associated complete patient information in minimum time and consistently every single day. So as a challenge, just think about, what are 6 different actions that you would take to improve quality in your laboratory? If you really think about it, there is a lot of different areas that you can look at. So to help along, think about them as either management actions, which, as I said, is sort of a global, or bench level actions. So from a management level, there's a lot of things to be considering. There's staff recruitment, induction, training, adequate training records, staff accountability, making sure that people are accountable for their actions, but also that you can trace to not just as a punitive, but also as an educational aspect. You've got to consider different shifts, different tasks to make people also interested in what they're doing, rotating through different areas in the laboratory depending on skill sets, professional development, staff morale. There's participation in QA programs, interaction of all the staff, including the pathologists. You've got to think carefully about your selection of your instruments and equipment, maintenance, reagent quality and supply, lab layout, conditions workflow, specimen tracking system. These are all just some of the management level quality factors that you need to consider. But from a bench level quality factors, and this is what we'll be focusing on today and in the next session, these are just some tips and ideas of where to look for when you're looking for quality and how to bring quality into your laboratory. So we'll be looking at the pre-fixation damage, fixation, grossing and processing. The next session will go through all of the other workflow stations. But as you can see as the graphic on the right-hand side here, quality, there is so many different aspects to it. There's so many things that can go wrong. There's so many areas to really look at. You've really got to assess a lot when you're, say, looking at a slide and deciding where problems are. So I guess most people would be familiar with garbage in, garbage out. This is from Bracegirdle, The History of Microtechnique, probably written a long, long time ago, but the same applies. If a tissue is not in a healthy living state when it's fixed, it can only reveal abnormal details, no matter what the subsequent treatment is. So looking at some of the prefixation damage, and here's just some examples, but it's well worth considering what effect might have happened before you actually got the tissue. There's heat damage, which might have occurred from diathermy within surgery. There's desiccation when specimens are left out of formalin for too long or fixative for too long. Maybe sometimes they're stuck to the lid of a pot. Maybe they'll put in water or saline instead of formal saline or in formalin. Crush artifact can occur particularly for fresh and very soft tissues. Autolysis, this is a quite extreme example that you can see here, but certainly how often do we actually record the cold ischemic time, the time between when the specimen is taken from the patient or the specimen and actually placed into a fixative. Every up to more than an hour out can absolutely affect the tissue. So what are the things that we can do here? We can document. We can actually look and document first. If we notice anything that's happened, we can look and notice what time a specimen was taken and then what time it was actually put in formalin. Often that will be on a request slip. If not, we can start to ask whether that can be. We can get the word out. Education, training, information sheets that show some of the examples and how we would think about fixing them. Pathologists can play a part. Internal and external communication, both from the laboratory to the pathologist out to surgeons. We can improve specimen transport, and we can think about what the lab actually does when we receive specimens, how we document and what we do. If we move on to fixation, and fixation is obviously really the most critical part of our tissue preparation, because if it isn't fixed correctly, we really have a poor outcome or potential poor outcome with all of our H&Es, with our morphological preservation, but also with all of our downstream processes such as our IHC, any of our molecular techniques. It is so critical to really understand the relationship of fixation into our preparation and our further processing. Some of the key things that we would look at is when specimens are put in inappropriate containers. Again, many times we see large specimens stuffed into a smaller container, and the tissue just doesn't have a chance of being fixed. So you may have recorded when it was put into fixative, but if it's not in the right container, it won't fix. In an inadequate volume of formalin, generally we would say at least 1 in 20. There are some recommendations to 1 in 50 of the ratio between formalin and specimen. The RCPA, which is the Australian Royal College of Pathologists, recommend at least 1 in 10, and that would probably be inadequate. So rule of thumb, 1 in 20, 1 in 25. The quality of the fixative, you do need it to be at pH 7. Anybody who is perhaps used to making up their own formalins might have more problems than this in some of the commercial formalins, which are controlled and standardized a lot more. But certainly the issues that you see with a pH are manifold. So a more acidic, we might get formalin pigment. If it is too alkaline, we may find that we're not actually able to fix correctly. There's no binding or cross-linking. So it is really critical to get the pH correct. And also if there's tissue fragments that are roughly handled and break up in, during fixation. So some of the consequences that you might see when you're looking down the microscope, you could see nuclear evacuation, where the nuclei has not been preserved well enough. So you'll see holes. Again, not a lot you can do at this stage. Shrinkage and separation. We see formalin pigment, as I said, if they're a more acidic pH, you will get formalin pigment. And zonal fixation, which is a real issue with a lot of laboratories where the outside of the specimen is fixed, but the remaining specimen or internal specimen is not correctly fixed. And some of the consequences you see, you might pick those up in IHC in particular, where you can see that you have uneven staining due to zonal fixation, or poorly fixed tissue, which just is not able to be stained correctly, regardless of your antigen retrieval. This is just an example too, and again, this is quite a common problem that we do see, is that the tissues are fixed or completed fixation in ethanol. And obviously this is the same tissue or the same 3 different tissues that were taken. We developed these in-house. So one is formalin fixed, and we can see a completely different look when the tissue was fixed in ethanol. There's a large degree of shrinkage and far less detail in the ethanol fixed. Often in a more modern laboratory, there is some sort of compromise between here, but you can see what a devastating effect it has if the formalin is not allowed to fix the tissues correctly. So what makes an ideal fixative? And just to preface these comments is there really is no ideal fixative. We are very used to some of the artifacts that a fixative has, but effectively it is taking a fresh tissue and putting it into a preserved state. There will be some alteration and there's some compromise in any fixative that you select. So you want it to react rapidly and completely with the tissue without removing any of the tissue. You want it to penetrate rapidly so we don't get issues with our zonal fixation. You want it to be stable because once we put it into tissue processing, the tissue processing is obviously temperatures and pressures and lots of harsh solvents. So you really need it to be well able to withstand what's going to happen to process that tissue. We want it to be minimally distorted by swelling or shrinkage. We want it to be hard enough so that we can actually handle it well. We can gross it correctly. We want to be able to do all of our staining methods and our molecular techniques. We want it to be left in fixative indefinitely and without harm, but we also want it to be cheap, non-toxic and non-inflammable. So it is really difficult, if not impossible, to ever find a fixative like that. But formalin fixation is really the compromise that is accepted universally. So the reasons here are because it's stable, it's cheap, it favours basophilic staining, most stains are possible, the tissue consistency is okay, and pathologists are used to the artifacts formalin produces. The tissue shrinkage is acceptable, morphology is acceptable, and you can, which is really critical, is leave it in fixation for a longer period of time, which some of the alternatives may not actually allow you to do. However, it does penetrate relatively slowly compared to, say, an ethanol, for instance. It fixes relatively slowly. It's unpleasant to smell. It's toxic. Not as good results with acid dyes. It requires retrieval for IHC and ISH. Formalin pigment can be an issue, and you do need to buffer the formalins just to keep them in the pH that you require them to be in. Of course, there's a lot of commercial non-formalin fixatives as well. There's just some examples, and of course there's even more modern fixatives that are on the market, but just consider when you are thinking about a non-formalin fixative that you really need to evaluate for tissue preservation and for IHC and molecular techniques before the introduction into the laboratory. And this, again, is really critical because different fixatives have different reactions on the tissue. They may be developed for one particular technique. There are some that are specifically designed for molecular techniques. They don't always give you the morphology that you require. And as I said, the storage conditions is really critical as well, because with fixatives, there are, again, some on the market that they don't recommend you fix for longer than 7 days because it is not preserving the tissue. Even in formalin, you really should be changing the formalin if you are storing for a longer period of time, just so that the formalin doesn't, the formaldehyde doesn't polymerize. So some of the fixation factors that you need to consider is the rate of penetration and diffusion, and also the rate of reaction. So there is what we call the penetration reaction paradox. So while the penetration is relatively fast for getting into the tissue, the reaction is slow, and there is a series of quite complex chemical reactions that occur over time. So we see first forming the methylene bridges with the lysine, purines, primary amines, which are reversible. This is sort of the basis of our antigen retrieval. But then there are some continuing cross-linking that goes on, eventually getting to an irreversible state. There are also, for clinical laboratories, there are some recommendations here for, again, really looking after what is going to happen for our sort of more prognostic or predictive markers for IHC or for ISH. So there are recommendations globally handed down. The American, Society of Clinical Oncology and Pathologists have put forward some recommendations, and these were put out in about 2010 and still current. So essentially what is recommended for 10% neutral buffered formalin is a minimum of 6 hours and a maximum of 72 hours. For HER2, the recommendation is really no more than 48 hours in formalin before tissue processing occurs. They also recommend, again, as good practice, but also so these are class 2 and class 3 antibodies, that we also record the cold ischemic time, the fixative type, and the time it was placed in neutral buffered formalin. So remember the basics. Fix tissue as soon as possible. If it's not possible, then refrigerate at 4 degrees. Do not freeze the tissue. Fresh tissue can be infectious. Do not distort the tissue. Need to label carefully and always consider downstream requirements for IHC and molecular techniques. Preparation is important. For proper penetration, we want the fixative to penetrate from all sides, which means that we do what we might call breadboarding, or slicing the tissue if it's a larger tissue, to just make sure that we slice so that we try and keep perhaps the shape, but we also make sure that the fixative has an opportunity to penetrate in. Cavities should always be opened. Perfusion of some specimens can be advantageous. The thickness is really important. Some recommendations are between 10 millimeters thickness if you are what we call breadboarding, which is slicing at different intervals. Some agitation can be useful. Not always possible, but it can be useful just to change the diffusion gradient for the fixative. Adequate volume of fixative is vital. Make sure that there is sufficient time and room temperature is satisfactory. Heat will increase penetration. Right choice of fixative. So make sure it's carefully made up from suitable quality reagents and at the correct pH. Just remember that many commercial formalin fixatives contain up to 10% methanol. The reason they do that is for stability of the formaldehyde, so that we don't form a whole lot of polymers, and which also mean that it doesn't penetrate as quickly. Check the specimens received in fixative and replace if necessary. Again, just so that we have a stable formalin. Use once only for primary fixation, and use appropriate fixation step if that is required. Remember that fixatives are toxic and irritant. They're doing their job by fixing the tissue, which means they're not great for you. So moving on to grossing. So some common problems are getting where the thick specimens and are not properly fixed. As I said, we can see an image on the right, the lower right, which is what I would call breadboarding, but it is also just slicing up a sample just to make sure that there is an opportunity for larger organs particularly to get the fixative in correctly. How do you enforce this? It is really just good practice and documentation. So some of the problems that we see are specimens are too thick or too large for the cassette. Because of the thickness, the specimens don't process using your standard schedule, so not one size fit all is not always appropriate. In extreme cases, the cassette bars will distort the specimen as well. And you can see the artifact on the right of a severely distorted tissue that obviously did not fit correctly into the cassette. Remember that specimens do shrink during processing, sometimes up to 30%. The cassette choice must allow for this, so you need to have mesh if you need it, or biopsy pads or biopsy wraps. There is this risk of specimen to specimen contamination, and biopsy pads can present their own problems. On the right here is a biopsy pad artifact that is formed by the biopsy pad pressing down on the tissue. There's also, for many different protocols for tissues, for instance, for prostates, some for bowels in particular, where it is appropriate to use a larger cassette or a mega cassette. So again, this needs to be considered. The much bigger tissue is not going to fix, is not going to process in the same period of time. So again, trial and error, going through exactly what that tissue requires is really essential before introducing mega cassettes into your laboratory. So now moving on to tissue processing. So what do we look for when assessing and monitoring processing quality? So we'll go through a theoretical approach to optimize processing, looking at the advantages of batch processing based on specimen type and dimensions, causes of poor processing, and getting the best results from your tissue processor. So this is divided into two. So there's macro effects, where the tissue has unusual physical properties at embedding, or section preparation is difficult, blocks deteriorating rapidly. And then micro effects, which is the physical quality of the section is poor, tissue morphology could be poor, or staining quality could be poor. So some of our effects of our poor processing, as you can see, and many working in laboratory may be familiar with this effect, where we have not processed the center of the tissue. So the wax is correct, the block is holding up, but the tissue itself is not. And you do not get a section on the slide if the tissue is not processed correctly. So what we see here is 3 different views of a tissue. So we can see here that this is severely underprocessed tissue. So we're seeing on the left-hand side that the tissue is relatively well processed on the outside, bit difficult to see, but relatively. But inside we've got a lot of cracking. It's very dry. When we go further, we can actually see that we still have water remaining in the centre of the tissue. And this is because our tissue processing protocol was completely inadequate or too short for the size of the tissue. This is a really severe reaction, and of note, there are many different causes of something like this, which is blue hue, but this is one that people may see and not necessarily recognise straight away, that severely under-processed tissue can have these sort of, it looks like it's cracked, it looks like it could be over-dehydrated, but what is my actual problem here? So some of the effects of poor processing on section preparation: the block has poor texture. It may not be uniform. It may not be cohesive. The sections compress when you're sectioning them, and ribboning could be poor. In some cases that you can't even get a ribbon. You may see some poor results when you're floating and mounting your tissues. You may see here, that's just an example of where sections are sweating on the water bath because they've still got solvent within the block, or they separate out, or they're impossible to flatten out, where this is all due to the poor processing. Block stability on storage. If it's severely underprocessed, or there is still a lot of remaining solvent, alcohol within the block, you will start seeing shrinkage of that block. So that you may, and fabulous microtomists might be able to get a tissue off immediately, but certainly that block will deteriorate. And where blocks need to be stored for 20 to 30 years, this can be a serious problem. Looking at the micro effects, looking at the physical qualities of sections, this is where we would see that sections are disrupted. They might adhere poorly to the slides. They might be cracked, and they might be quite uneven in thickness. Quality of tissue preservation, you may see poor nuclear detail. You may see poor cytoplasmic detail. You might see, as here, that their special tissue features are disrupted, fibrous elements are poorly preserved, or the preservation is not uniform throughout the specimen. And staining. So while staining may pertain to the stain, what we're seeing here is that the effects of the poor processing is actually bringing and distorting our actual stain. So the staining may not be uniform. The nuclear staining, as in this case, is extremely poor. Cytoplasm is poor, or extracellular components are really poorly demonstrated. Again, look to your processing as much as your staining. So this is just a hypothetical model for looking at different tissue processing, and we're trying to demonstrate here is that different tissue sizes are optimally needing different processing protocols. Now, some labs may not have the opportunity to separate out tissues, but it's really worth thinking about what each tissue needs optimally, and if there is a way to match workflows in some way with the type of specimens that you have. So while there might be some overlap between small or medium-sized tissues, it is often quite difficult to actually have your minimum acceptable quality that suits every single tissue type and size. So really consider what sort of tissue that you have and what sort of size of tissue, and what protocol is therefore the best for either all the tissues, or separate out the tissues and treat them individually. So to optimise processing quality, process tissues in batches based on specimen types and dimensions if you can. But also, as with our management problems, you need to make sure that it also results in an effective workflow in your laboratory. So an instrument choice can be very important in satisfying these demands. So listing the 12 causes of listing 12 causes, not the 12 causes of poor quality processing. And if you try and think about them, there are a lot. We've gone through some ideas here. But here's just some that we've prepared earlier. I don't know globally whether this works, but a can of worms is a common phrase, that opening a can of worms, and it really just means it can be a mess. There's so many different causes of poor processing. As you can see, here's just some examples, like incorrect solvent, specimen type, faulty dehydration, incomplete fixation, poor clearing, poor grossing, and we go on. So what you need to do is really think about, go through, think about it in a very logical manner. So the causes of poor processing. The tissue wasn't fixed, as we saw earlier. Fixation is absolutely critical. Fixation time too short, or it's too large, or the specimen has not been opened before then you introduce it into a tissue processor with the harsh conditions found there, can really cause damage to that tissue. They may be too thick, they don't fit in the cassette. If they don't fit in the cassette, they probably won't process. The tissue is too dense for the time of your protocol, or fatty tissue, always a challenge. So consider separating out fatty tissues, or consider making sure that the fatty tissue is on the appropriate protocol. In fact, do more than consider, to make that essential. The tissue contains calcium deposits or foreign bodies. Make sure that you treat those appropriately. If the schedule is too short, so that specimen's not properly fixed, if fixation is also occurring on the tissue processor, not properly dehydrated, not properly cleared, not properly infiltrated with wax, or sometimes a combination of all of the above. Maybe the schedule was too long, so the delicate or tiny specimens were exposed to dehydrants for too long, or exposed to a high concentration of dehydrants for too soon, especially if the tissue is poorly fixed. You remember the example earlier of fixing in ethanol, so as opposed to having a well-fixed formalin tissue, or exposed to clearing reagents for too long, or exposed to hot wax for too long, or high temperatures for too long, or a combination of the above. There are many different ways, but the critical thing is to look at your protocol and make sure it is a well-balanced protocol, and that it is the appropriate protocol for the tissue. So if it's incorrectly proportioned, the tissue processing duration may be correct, but you may have all sorts of other issues. So you may have a 8-hour protocol that is fine, but the actual proportions of the reagents to each other is not correct. Could result in insufficient dehydration before clearing. You could get excessive dehydration before clearing. You can get insufficient clearing before wax infiltration, or insufficient time in wax, or excessive time in wax. So think about if there are any, there are many, many different articles, there's many different examples of what is a good protocol. So look at examples and validate those protocols for your particular set of circumstances, because recommendations can be based on a laboratory, for instance, that has perfect fixation because they have time to do that. Your laboratory might have other challenges that you need to look at, or your tissues may be routinely cut a little bit thicker than another laboratory's. So always validate, but look to references to get an idea of what is the right proportion of tissue, of steps in your tissue processing protocols. There's always problems that can happen with tissue processors too. So you could select the wrong schedule by accident. You can overload, which is sometimes trying to squeeze that extra little cassette in is really detrimental, because you need agitation and you need fluid flow around those tissue cassettes. Or you might be using the inappropriate cassettes. perhaps you've got tiny tissues and you lose tissue because they have shrunk and they fall through, or you've got really big tissue and you're trying to stuff it into a small cassette. You should always maintain your tissue processes, making sure that you use the right reagent when you change it. And whenever people are recycling too, this can be an issue, or storing waste in the same place as the new reagents, labeling waste containers or not labeling waste containers so it looks like it's a new reagent. If recycled reagents are used, look at the manufacturer's recommendations, because not all recycled reagents can be used as pure reagents. And this can have a really significant effect if you're looking particularly at alcohols, where you really don't want water going into your solvent. Water is not miscible with solvent, resulting in contamination. So making sure that you understand what your recycled reagents can actually do, what your recyclers can actually do. Sometimes people have been known to leave reagents within a retort before they actually start cleaning. This is bad. Inadequate training of staff. So whoever is maintaining the instruments, whether that is their only job, they need to be really clear and well trained on what is the effect, how important their job is in maintaining that instrument. If things go wrong there, it is difficult to get back. So we really try and instill quality early on. Reagent carryover during processing. So there's a lot of different things that actually influence how much carryover. And carryover, again, is really critical in when you determine whichever instrument you have, where you want to set your threshold for changing reagents. So you need to think again, look at manufacturers' recommendations, but again, look at your laboratory and understand, how much, the types of specimens that you have, the types of cassettes. Do you have a lot of different cassettes? Some cassettes carry over more excessive reagent than others. Standard cassettes might be a couple of mils, but fine mesh cassettes might carry over a lot more reagent. So just think about what you're using. The drain times between steps, many instruments will offer the opportunity to change that drain time. This can be important just to make sure that it's fully drained and you're not putting excessive reagent into the next clean, pure reagent. The retort design, reagent viscosity with some reagents, particularly some xylene alternatives. Reagent volume, what is the previous reagent? Do you have graded alcohols? How far do you allow those to go down before you change them? The temperature of the reagents, the basket design, number of biopsy pads or the type of biopsy pads. All of these can really have a critical effect on determining when you change your tissue, your reagents for your tissue processor. And this is universal. So there can be malfunctions, and again, these are just things that could cause the poor processing. Is there an older style tissue processor or it's drained and has not filled, where the tissue's left for a prolonged period of time without coverage, which would lead to drying? Are they immersed for too long? Not removed. One thing that people sometimes forget is that wax at the end of a processing, it will indicate that protocol is finished, but keeping it in wax for an excessive period of time you're actually giving a much longer protocol to that specimen. Specimens subjected to excessive heat could be in the embedding center. A tissue processor for that particular tissue, is that an issue? And being placed in contaminated reagents, such as wax being contaminated with formalin. Again, simple things like, where do you put your basket? Is it on top of the wax bath while you're loading and the formalin's able to drip in? These things can happen and they're user related, but again, formalin is not miscible with wax and it can lead to artifact. Specimens lost during processing. Have you considered, you've seen examples here, the cassette was inappropriate, the lid didn't close correctly, or some other way of losing, such as at the grossing board. So I've just listed 36 causes. The ask was for 12, but you can see there are so many different things to really consider. And it is really good to document, and it's really good to think about all of these different things that can get you into trouble. So it leads to analysing your problem. So when faced with blocks that are difficult to section, the first questions to ask: what was different about the run that produced the problem specimen to previous successful runs? If you have been using the same protocol again and again and again, the chances are that that protocol the steps are actually quite good. So is there something else about that particular protocol, or is there something else that I need to be looking at? Was the intended schedule actually used? Did I select by mistake a 2-hour protocol instead of a 4-hour protocol? Does my problem affect all the specimens in a batch, or just a small number? Or are they all of a similar type? Did they come from the same source? Were my specimens at the very top of the retort? Is there a chance that the basket was not placed correctly and the specimens were not covered correctly? And do I know with certainty what has gone wrong? This is really, as you can see, there are so many different areas that you really need to be very clear of what you think went wrong. As I said earlier, when my specimen's processed using the usual schedule, it generally produces good results for this size and type. Is it likely that the schedule was too long or too short for my problem specimens? Is it specimen related, or is it actually a more systemic problem? If it's a tissue processor malfunction, do I definitely know what problem? Did the software indicate? Was there an error in the run? What about a visual check of my reagent bottles? Is there a possibility that an error could be made when replacing solvents or any of the reagents over their recommended purity thresholds? Was normal fixation applied to my problem specimens? So all of these questions can be a way of starting to find out or dig down into what could go wrong. But if you're uncertain, think about all the things that have been discussed here of where different issues can happen and how we can inbuild quality into our process, but also how do we examine when things have gone wrong? Where do we start looking? And your nose may help determine where the solvent remains in the tissue. Think about how you describe your block. Is it crisp and crunchy or brittle? Is it shrunk and shriveled? Is it cooked? Sludgy, greasy, mushy? Dry, powdery, contains hard fragments, smells of clearing agent? Is it soft and compressible? There are different ways people describe it, and sometimes they're not always helpful. As you saw in an earlier slide, crisp, it may look like it's really hard, but when we look at it, that tissue is actually under-processed. Sometimes it could be crisp because it's over-processed. So it's a bit of detective work in thinking what can have gone wrong. If it's over-processed, there are different ways of treating than if they're under-processed. Under-processed, there are some recommendations again of what you can do. It will depend on what has happened to that tissue. So you need to be really clear about what has happened before racing into reprocessed tissue. Again, some more descriptions. Think about, is the outer rim satisfactory but the centre's poor? Is it poor consistency throughout? Is the outer rim brittle? Centre's satisfactory? Are there just discrete layers or are large areas poor? Is the specimen separated from surrounding wax? And finally, just having a look. These are two different, these were prepared in-house. It's the same kidney. They were both put on an 8-hour schedule, but you can see on the left, this is beautifully processed. On the right, not so much. So I don't know how we could possibly do that, but any suggestions on what is the problem here? I don't know how I look at this. Katrina, are you?
So Blake has said poor fixation.
Mm-hmm. Any other suggestions?
Over-processed. Shrinkage.
So you can see there's a lot of different things that it potentially could be. So what it actually is a difference in thickness. So what we had here is an 8-hour schedule. We've got the same kidney that in this case, I know that it was cut in half. So it's the same, exactly the same kidney. But what is different is one half was 3 millimeters in thick and the other was 4.5 millimeters in thickness. For this size of the tissue, one processed really, really well and the other didn't. And as I said, it's a lot of detective work that can go into looking at it. But hopefully this presentation has given you some good ideas about our pre-analytics, fixation particularly, and our tissue processing.